Next presentation, Peter Janevski from Macedonia, Flowdiverter in case complication.
Thank you. Good afternoon. Today, I have nothing to disclose. Today, I'll be presenting a case of a ruptured paraophthalmic aneurysm that took 2 sessions to treat, of course, with complications. So our patient was a 52 years old female with ruptured paraophthalmic IC aneurysm. So we decided to treat her endovascularly. There was no antiplatelet therapy given, of course, because it's a ruptured case. Only IV heparin was given in the beginning of the procedure. For this case, we opted for non-occlusive remodeling net-assisted coiling. And we used the Cascade device. I don't know if anyone knows this device. It's basically older version than of Comaneci. It's similar to Comaneci. But the difference is this Cascade has a denser mesh, and that's why it's more thrombogenic, of course, but we didn't know that in that time. Here you can see the positioning of the Comaneci device, one microcatheter in the aneurysm, the other is in the MCA. So we deployed our Cascade device and started our coiling procedure. So after a while, because it took maybe 10 minutes, the Cascade was open for 10 minutes, so we were afraid that something might happen. And of course, we were right. As you can see, there's a filling defect in the M3 segment of the MCA. So we stopped our coiling procedure here, and we continued with our rescue strategy, which was tirofiban, intravenous bolus, and then in the next 12 hours, intravenous tirofiban. The patient recovered well. She had no neurological deficits, and after 2 weeks, this is the control CT. As you see, small cortical infarction, but everything was okay with the patient. So the patient didn't show up at her scheduled appointments for control, and she showed up after maybe more than a year after the initial treatment with a CT from another hospital. In which we see that the aneurysm is, of course, recanalized. So we did the DSA, and we saw this huge recanalization of the aneurysm with the coil compaction. This is the 3D of the same aneurysm. As you can see, the thing that worried us the most was this outflow stenosis. Not just this stenosis, but the whole segment is stenosis because of the compression from the aneurysm itself. So we continued with our plan to put the Flowdiverter here, and hoped that this stenosis is not severe enough or it's not fibrous, so the Flowdiverter has enough radial force to open this stenosis. If not, we were ready. We had the balloons prepared and everything. So we had our plan. 7 days prior to the procedure, the patient was on double antiplatelet therapy, and we did the clopidogrel resistant test, of course. This is the initial angiogram, which was more or less the same as the one we did 2 weeks before. So the implantation of the stent itself was uneventful, but we saw that it didn't open at the level of the stenosis, of course. We expected that. I don't know if I'm allowed to say. I'm just kidding. It's FredX. So this is the part where the stenosis was. So this was the control angiogram. And we hoped that it's enough. But of course, we waited for a few minutes to do the check. And of course, the next angiogram showed this. When you see this, you know you're in trouble. So we hoped that the long sheet has fallen down and it went to the external carotid artery. So we went to see what's happening down. And of course, the long sheet was still in the ICA and the flow diverter was occluded. I don't know if you can notice the patient is moving. We do almost all our procedures in conscious sedation. So yeah, we didn't do. I know the follow-up question would be, did you do balloon occlusive test? No, we didn't. But we're doing it now. This was 3 or 4 years ago. So from this case onwards, we're doing it. It's our practice, but in this case, we didn't. But we checked the neurological signs. There were no deficits. The patient was okay, and the carotid was occluded. So we knew we had time. So again, in the same patient, we're doing the rescue strategy: aspiration thrombectomy, tyrofiband, IV bolus, the infusion, this time 24 hours. And afterwards, we aspirated with the Sophia 5 till the level of the stenosis, because, of course, the Sophia could not pass the stenosis. It was a tight stenosis. So we tried first with with compliant balloon, but we were unsuccessful. Then we changed to semi-compliant neurospeed balloon. And as you can see, we recognized the flow diverter, but there's still some thrombosis on the wall, but we left the tyrofiband to do its job in the next 24 hours. So this was the final run. And 1 year follow-up, this was done actually last week with the radial access. This time the patient showed. And you can see the flow diverter is open, completely open. And this is the final angiogram. As you can see, beautiful remodeling of not just the neck, but the whole artery. So we were very happy with the result at the end. In conclusion, I can say that thromboembolic complications can happen, of course, during embolization of ruptured aneurysms. That's expected, especially when you use bare metal devices as a support. And as this case showed, it can happen during elective cases with prepared patients, but usually they don't happen in the same patient twice, usually. But this was the case. So we have to be prepared for everything and have our bailout strategies prepared in advance. Thank you for your attention.
So no blood, sweat, and tears in this case either. Any comment?
Quick question. Thanks for sharing the fantastic case and, of course, a great salvage as well.
Sorry, I can hear you.
Sorry, thanks for sharing the fantastic case and
You're welcome.
good salvage as well. A quick query. Do you think that stenosis was a real stenosis, or it was just because of the angle?
The bend. Yeah, we thought it's just the curve, because that's why we couldn't pass with the Sophia, but we tried with the scepter. It didn't open. So yeah, it was.
Because if it's a real stenosis, we have seen that 6 months later when you do a angiogram, the artery would be occluded, if it's a real stenosis.
We did the PTA with the semi-compliant balloon, and at the end, that was the result after 1 year follow-up.
Yeah, usually the problem there is that the carotid is coming out of the cavernous sinus, so there is the dural ring there. So whatever pushes on the carotid, it will just obtain a stenosis of the carotid, because it's a hard thing keeping it there, cannot move around. And so that's why at the follow-up, it's no more there. Mm-hmm. Would you do something different next time?
No.
You never learn from anything, huh?
Maybe in the first case, with the non-occlusive remodeling net, I wouldn't use it now. That's what I learned. About the flow diverter, no, I was ready, prepared with the balloons. I knew that this can happen, and I was expecting it. So
sometimes when you have such a stenosis with the flow diverter, it can be helpful to place a coronary balloon to reopen the flow diverter. Of course, it's not at all on something you should do always, but off-label completely, it could be helpful. Please?
I think your conclusion is very good, and for the audience, I would say and suggest never use these kind of devices, especially not without proper antithrombotic therapy, because there are a lot of wires, and if you keep it, like you said, 10 minutes, this will almost always cause thromboembolic complications, even if you have clopidogrel on board. It can, because if it's not fully open, it is not attached to the wall, then the wires are in the middle of the blood stream. So they will, and in my experience also, I made it like I played with the ordinary stent, not just a flow diverter, just an ordinary stent like your device, and it was not fully open. I got thromboembolic complications distally because I wanted to open, and I played it like pull a little bit or push, whatever, to place in an optimal position, and I realized it's dangerous. So your conclusion is very good, and for everyone, don't use.
We were expecting that. We were afraid that it will happen because the 10 minutes was too long. We put like something like 8 coils there, and we were like, let's check if something happens. So the effect was what we expected.
Okay, thank you very much.
Thank you.